Okay, I got Ebstein's Anomaly for my pediatric presentation. What is Ebstein's Anomaly? It's a congenital heart defect that affects the tricuspid valve in infants. This causes regurgitation into the right atrium, which then causes right atrial enlargement. This anomaly was described by Wilhelm Ebstein in 1866, and he first diagnosed this in a 19-year-old male with signs and symptoms of CHF. It accounts for less than 1% of birth defects in infants, and it is very rare, with there only being 1 in every 200,000 babies born have Ebstein's Anomaly. This picture is really good. It's from the Cardinal Glennon website. It shows that heart on the right, that atrium droops down, and that's going to cause the regurgitation into that right atrium. How and when is Ebstein's Anomaly diagnosed? It's diagnosed by using echoes, EKGs, chest x-ray, or even an autopsy. The echoes are going to show the ejection fraction and backflow of blood into that right atrium, and it's also going to help them visualize that tricuspid valve. EKG is going to show tall, broad P waves and prolonged PR intervals. Chest x-ray is going to show an enlarged heart, usually that right-sided enlarged atrium. It can cause fetal demise, then it would be determined with an autopsy. But Ebstein's Anomaly can be diagnosed at any point in life, from when the baby is still a fetus to adulthood. What are the manifestations of Ebstein's Anomaly? Usually in infants, cyanosis is the primary sign. Their APGAR scores don't really improve with their with time out of being out of the womb. They also hear a murmur upon auscultation, and when the child gets older, they could complain of palpitation, shortness of breath, or chest pain. They can also have some signs and symptoms of CHF, and a lot of kids, when they're running on the playground, they'll have some dyspnea with exertion. How is Ebstein's Anomaly treated? When we start treating it in infants, when they're born, we give them prostaglandins to help keep the shunts open in the heart so they still have adequate blood flow until they're able to correct that abnormality. Surgical repair, sometimes they can repair the valve instead of doing an entire replacement, but this all depends on the severity, of course. Sometimes a repair is done to help strengthen the valve or reinforce it until the child gets older, and then they can do a replacement of the tricuspid valve. A replacement can be mechanical or biological. Obviously, both come with their own risks, but that is up to their doctor. What is the expected prognosis? Prognosis usually depends on the severity of the case, but the child usually lives until adulthood. The patient will be on chronic medications and have frequent cardiac checkups, and they will need a really good relationship with their cardiologist. They can be on anti-rejection meds if they have a valve replacement, prophylactic antibiotics to prevent endocarditis. It can cause congestive heart failure when they would need to be treated with diuretics, digoxin, and medications like that. So my nursing diagnosis and intervention is a decreased cardiac output related to structural defect of the tricuspid valve, as evidenced by cyanosis, shortness of breath, dyspnea, palpitations, and chest pain. So on your focus assessment, you're going to auscultate heart sounds every 2 hours to make sure that they are not getting worse, or their murmur's not getting worse. You're going to monitor their skin temperature and color, make sure they're pink and warm, make sure they're not cyanotic and cold. You're going to administer oxygen as prescribed. Usually with infants, they do need oxygen because they don't have great blood flow anyway, and then give them an abnormality on top of it. You're going to assess for lethargy. That's kind of our first sign of hypoxia in infants. You're going to monitor your vital signs routinely, hourly, and then you're going to do continuous oxygen saturation monitoring to make sure they're getting adequate blood flow. In this picture on the right kind of really shows you a severe case of Ebstein's Anomaly. That left atrium and ventricle are super squished over to the side. That right atrium is taking up the majority of the heart, and that valve is not going to close. It's going to keep backflowing and keep causing that regurgitation. So they are not having great output by any means. I also use the websites Cardinal Glennon and CincinnatiChildren'sHealth.com.